If God closes a door, he opens a window. And, that sticks. I was very little when I saw that, but it stuck with me. You always have, if the door closes, look for the window. Because there are more windows than doors. And you have to look at life that way.
We are back with another episode of the Spine Pod, and I have a girl crush.
So do I. We got to sit down with Dr. Evalina Burger here at the University of Colorado in Aurora, outside of Denver. And this place is amazing, but
beautiful.
She is absolutely incredible.
Absolutely incredible. I'm just still in awe. I'm still taking in the conversation we just had with her of just what a life that she has had and what a perspective she has. And it was just incredible. It was really incredible.
Absolutely. Well, I've always seen her as a leader in the spine community, and she absolutely is 100% across the board. She does complex spine surgery, and she does large deformities and scoliosis and motion preservation. Yeah. But her life in general is in the things that she has done and the things that she's accomplished is absolutely immense. And 99.9% of people would not be able to get through some of the things that she's dealt with. Mm-hmm. And then to have a positive perspective on the other side and to make everything that she's created out of it, it is absolutely astonishing.
Mm-hmm. She talks about being from South Africa and that South Africans are really rebels. And I loved that because it's such she takes a positive spin on that word and really owns it so well of just her commitment to her craft and saying this is her calling, and it is so clear that she is in her calling.
Yep. And when I hear rebel, I hear innovator because that's what she is. Yeah. I mean, she is an innovator. She's constantly learning. She talks about her natural curiosity, which not just in medicine, but in general is an amazing trait. She talks about not only teaching, but being a listener. Like the craft that she has created and the amount of education that she does, to fellows and residents and to the whole orthopedic community. She's the department chair of orthopedic surgery here. I mean, she has carved out a niche and she is doing an incredible job here.
She really is. I want every single person to listen to this and watch this episode. It's one that you can't miss.
You cannot. And this was incredible. And I think we jump right into it.
Let's do it. Enjoy this episode with Dr. Evalina Burger.
Dr. Evalina Burger, it is a privilege to sit down with you today. Thank you for taking the time.
Thank you.
Absolutely. We were so excited. We've been talking about this one for a long time and being able to sit down with you. You are a leader in the space of spine care. And, if your awards here don't talk about it, you recently won the first Distinguished Women in Spine Award from State of Spine. You were also the first, I believe, female surgeon in South Africa to be an ABC traveling fellow. I think you do a first in a lot of different generations, a lot of the work that you do. I think what we'd like to start with is taking it back. What brought you to medicine in the first place and kind of your story leading up to what got you to medicine?
If I did what I did when I was a child, today I would be enrolled in a psychiatric program because I used to do surgery on my dolls when I was 5 years old. And I would make these longitudinal incisions on their arms with my mom's lipstick and then, do the sutures. And I got many a hiding for spoiling the lipstick. And then the doll had to be washed, it was those days. But I just had this fascination that I always make believe. And I played with my doll and pretended that she broke her arm. I mean, since I can remember, I played with my dolls. They were always sick. And I was always nursing them, so it was just like, this is what I do. So my dad wanted to be a physician, but the Second World War broke out and he was drafted. So, grew up on a small ranch in South Africa, no opportunity. And then when I was a little girl, he went into what we would today call EMS. After work, he would do volunteer for EMS. So it was just part of the culture in our house that when everybody had something wrong with them, whether it was a dog of an ingrown toenail or somebody that fell, my dad would always go and help them. So it's part of how I grew up.
That's awesome. So your dolls had a good caretaker then.
Very good caretaker.
You also broke them, but you fixed them,
I
right?
fixed them, yeah.
It's funny when we hear the story, we've heard a lot of surgeons tell kind of that same story of, it's not so much that you went into it, but it was almost like a calling, like it was born within you and you had this innate desire to, whether it's like help or solve or heal. It's such a fascinating story. So go back to there. You said you grew up in South Africa, and that's where you did a lot of your initial training. You did your undergrad, the University of the Orange Free State. I believe it's just the University of the Free State now. But can you talk about, your early years in education and then how that kind of evolved into your medicine career?
I went to a regular public high school. In those days, in our country, we had a quota system for women. They would only allow 20 women per year into the medical class. So it was a long shot. And then I finally got into the University of the Free State and life happened and I decided to do a bachelor's degree in nuclear science because I didn't want to waste 1 year. I needed one subject. And I thought, I'll just switch and then take this subject and then go on, only to learn that once you give up that medical school acceptance, you can never get it back.
Oh, wow.
So I finished that bachelor's degree, worked in nuclear sciences for a while, and started to do some research. And I got accepted back in the medical school class, which was like, if I think back today, I really know how blessed and how fortunate and how lucky I got to do that. So finished medical school. During medical school, was very interested in surgery. And then also worked in a time in our country when we had a lot of political unrest. It was before the release of Nelson Mandela. So rioting in our country, as you know, from political news bulletins were really high up. So you're this young doctor thrown into these rural hospitals where people would come in by busload from rioting. And so whether you had the skills or not, you learned to be a surgeon very quickly. And I was a little bit disenchanted after medical school when I saw what the care on the ground was. And I go like, this is not what I studied for. I studied to take care of people, not to just patch them up with Band-Aids and do triage and minimal care. So I decided to study law. And I went to an ICU conference as an intern, ran into my old surgery professor and says, what happened to you? How did you leave academics? And I said, well, life happened. I got a job there. And he said, I'm so disenchanted. And he said, you should come back. And I said, how? And he said, the military is looking for surgeons. I go like, the military? Okay. Pick up the phone, make an appointment. He made a call, got to interview with the CEO of the military hospital, who was a brigadier, and the Surgeon General. And he looked at me, he says, we don't have women in combat. Why should we take you?
Wow.
And I said, I don't know. I'm just looking for a job. And he looked at my transcripts and he saw that one of my examiners was a military person, picked up the phone, and she was a pediatrician. And she walked in to the office and gave me a look. And she looked at the CEO and she says, you can take her. She was the only medical student that couldn't get into tears. She can do this job. That's where I am. So became what's called a medical officer, had the rank of captain in the military, and got involved in orthopedic surgery, which I never thought I would do. But it was so busy because we were fighting the war in Angola. We were giving humanitarian help to the Angolese people. So they literally came down at night to South Africa in aeroplane loads with DC-10s. And also lost a lot of my school friends because men were conscripted. And I remember the nights when I was the CEO of the hospital because of my rank, and the commanding officer would come over to me and give me a hand of dog tags, and I would look at the tags, and I would have to phone people, and I had to phone people that I grew up with, and it still stays with me today.
Of course.
It was really tough. I'm sorry.
No, absolutely.
But fast forward, I embraced what I did. I saw how devastating war and landmines and everything can be, and then realized that the people I can help the most were the people with these gunshot injuries. And so I applied for a position, didn't get it because I was a woman, and there was no women in orthopedics. And then I kept on working in the military, and I was blessed to help a couple of high-ranking officers, and they did really well with emergency care. And the next thing, I got a phone call from the university, and they said, "We believe that you're doing an extraordinary job in the military. We will give you a probationary appointment." So regular training for orthopedic surgeons of 5 years. I did 7 years. I did 1 year of probation. And then I got married, which was an absolute no-no. And then I had a baby, and I took 3 weeks off, and they made me repeat the year.
No way.
But I did it. First time ever. I did it. First woman, first time to have a baby. Extended my training by 2 years. When I complained, they said, "If you don't like it, you can quit." So what doesn't break you makes you stronger.
I mean, that's a testament to that statement for sure. I mean, at every corner, you had to climb a higher mountain than everyone else around you.
I never saw it that way. For me, this was just like, okay, I got to do this. You know, I was nimble. I never said, "Oh, woe is me." I just said, okay, I'll do that. You know, when I look back and I look at it, I'm sad. I'm sad that I had to go to those extents. I'm not bitter. And I'm so delighted to be in this position to pave the way for fair treatment. That's all I'm asking. You're not asking for special treatment. You're just asking for fair treatment and acknowledgement of your skill sets.
I think you got awarded the Cornelius Wessels medallion as well. So you've had a lot of these firsts, and the awards are great, but I think some of the other events that you've had are just as important, if not more important than some of these awards that you've been granted. And when you go through some of these, you say you don't see them as hurdles, but you essentially hit this inflection point, right? Where you can either do this and carry on, or you can give up. When you're looking at dog tags of some of your best friends and people that you grew up with, that would give so many people the reason to say, "I'm going a different route."
And this is completely understandable.
Yes,
right?
Absolutely right. But to push on through that and say, no, there's a reason that I'm doing that. I think there's a reason that you're here today, right? Because most people wouldn't get through those phases. They don't get through those events.
I think it's two things. You cannot do this if you don't have a calling, if you don't absolutely believe that you can make a difference, whether it's for patients or the world or the people around you. The other thing you need to understand is the historical perspective on South Africans. We are a country that was founded by rebels and explorers and people looking for adventure. So it was the main route was around the tip of Africa for the trade between India, because the Suez Canal wasn't built. So if Europe wanted anything, they had to sail down the east coast of Africa, around the tip, Cape of Storms, and then up onto the west side to India. And so the Cape was discovered in 1492 and then settled in 1652 by the Dutch. And they came with 3 ships, and they planted the Dutch flag, and they started to cultivate grapes and fresh food so that the ships that would come could stop, because a lot of the sailors died from scurvy. And then in 1750, the French Huguenots came, and they fled France for freedom of religion. So here you're talking about people that are rebels, wants to be free. You're talking about explorers. And then in 1820, with the expansion of the British Empire, the British came and planted their flag and said, "Now this is a British colony. You will not speak French and Dutch anymore. You will only speak English." And guess what they did? They packed their wagons and they went inland into Africa, and they explored, and they had to fight a lot of tribes. It's the same as the West, exploring the West here. It's exactly the same. The timeline is the same. So people talk about Midwest Americans. South Africans are the same breed, You don't see anything. There's no giving up. There's no turning back. You just do what you do, and that's how you grow up, So I think that's a lot to do with knowing your roots and a lot of genetic traits that I carry from my forefathers. My mother is 92. She lives with me, and she rules the roost. So same genetic traits.
I think it's a great trait to have, and you don't see it as often these days, right? And just sitting here as a woman, I'm just like already in awe of you, and just like that, it's just amazing to see my appreciation for that perspective that you have, because it is easy to say, well, my starting line is way back here, and so I'm just going to be mad about it. But you're right. It's like you say, if I want it and I believe in it, then I'm just going to do what it takes to make it happen. And I just love that perspective so much.
I think it's the same as an athlete, and we're all differently gifted and talented. I am definitely not an athlete, but athletes, if you look at the Olympic Games that's just passed and you look at these amazing people and their history and when they were little and how they wanted to do this, and it took them their whole life and they never gave up. Yeah. So I did think about it that all of the people that work in this department are Olympic gold medalists, because I'm privileged to have this faculty of more than 86 surgeons that are all on the top of their game. They're all nationally recognized, and they're all Olympic gold medalists. They just show up at work every day. They don't complain, and they want to do the best for every patient.
I think that's finding where you can drive value too, right? Like finding that niche of where you can truly drive value. I mean, the spine community as a whole is appreciative of everything that you've done, right? And you use the word rebel, which I think is really interesting. I think we'd like to call that, difference makers and pioneers, right? Because those are the people who are pushing things forward. And so that story, it resonates. And now it's funny when you like put the puzzle pieces together, you're like, oh, I can see the picture now. Like this makes more sense of how you're able to accomplish some of these things, because these are hurdles, whether you think they are or not. I mean, there are huge barriers to get over, and how it's paved the way for not only females in this space, but so many other people that are pushing forward new technologies, new procedures, and all of that. So talk a little bit, you finish up your education in South Africa and now you're in the United States. So what was that transition? Did you always know you were going to come over to the United States? Like, was that from the ABC Traveling Fellow program, or how did that transition happen that you ended up at LSU?
I was a staunch, and still is, at heart, South African. And I do want to say I finished my orthopedic training, and then on the 20th of September 1993, I had a significant spinal cord injury. I fell 20 feet high, and I occluded my vertebral artery, had a cardiac arrest, and had a C5-6 disc. And when I woke up in my own ED, and I lay there and I realized, but I can't get my thumb out of my palm, and I can't feel my foot. Again, I had to push through. I wanted to be a hand surgeon after I did all of this work in the military with landmines and limpet mines, and that's what got me into it. And then I go why did this happen to me? What is the message? And I made a covenant with God, and I said, if you make me walk, I will do spine surgery, because now I know what it feels like to lie here at the mercy of people around you, and you can't even lift your thumb out of your palm. And I pivoted 180 degrees and then pursued a lot of people all over the world to learn the best I could learn in spine. It was very much impossible for me to, at that time, travel and do a full year of fellowship anywhere. But I had the privilege of knowing great people through the AO and worked in France, England, Switzerland, and the US. And then every time came and learned a piece of technology and took it back. Then I became an ABC fellow, and that was right when there was a lot of political turmoil in the country. It is the combination of a new regime, the high point of HIV in Africa, and opening of our borders. And that led to an absolute flooding of the health system in South Africa, which was in the top of the world. We did the first heart transplant, and we had 100 people survive before the first one in New York actually survived. So we were gifted surgeons. But in a small country where you have limited resources, what happened was that they started to say, I can only do one scoliosis case a month. Because if you have $100 and you have to choose between a starving child, a deaf child, a person with HIV and a scoliosis kid, the scoliosis kid's going to lose because you're alive, you can walk. This one can't hear, this one can't eat, and this one's going to die. So I looked at this and go like, I spent all of this training and now I can't do what I want to do. And then after the ABC fellowship, I got several job offers, was on my way to England where I'm also licensed to work. And I got this amazing call from Dr. Robert D'Ambrosio from LSU who had heard me give a lecture there. And he says, Burger. I go like, yes, Dr. D'Ambrosio. He says, I hear you're leaving. You're coming here. I go like, oh, yes, sir. And he is very convincing. He became my best mentor, best friend, and my sponsor. And here I am.
It's such a powerful story when you talk about your spinal cord injury too, and how, we talk about this concept a lot of, when you're trying to achieve your goal or whatever you're working on, bad things inevitably happen somewhere along the line, right? And it's really easy to take the first mindset that you said is, why is this happening to me, right? But that event puts you to where you are today, right? Like this thing that you thought, this is a terrible thing, I would never put this in my life, like why would I have this thing happen to me? That puts you on this new path to give you everything that you've had and like all the change that you've made and all the impact that you've had. I just think it's fascinating and immensely powerful to hear about how people take those and instead of kind of curling up and saying, I'm going to go a different route, saying like leaning into it and saying, nope, I'm committing to spine because people need this. It's powerful.
Yeah, thank you. Grew up in a musical house. My mother was a music teacher and I was an avid pianist in high school. And I looked at this and I go like, I wanted to be a concert pianist. And my mom said, it's not a good job for a woman. You'll be better off being a nurse because concert pianist works at night. My mother had no idea in healthcare.
Yeah, that you work 24/7 now.
That you work 24/7 now, I often wonder if I became that concert pianist, if I wouldn't have a better life. But it's just, I'm not complaining about my life. But I think the reason I bring up the music is if you ever listened or saw the movie or the play, The Sound of Music, when Maria goes to the Mother Superior because she's falling in love with this man with the 7 children, and she doesn't know what to do, the Mother Superior says to her, Maria, if God closes a door, he opens a window. And that sticks. I was very little when I saw that, but it stuck with me. You always have, if the door closes, look for the window. There are more windows than doors. And you have to look at life that way.
I couldn't agree more. I absolutely love that philosophy. I think a lot of the people that we've seen that have been able to do what you've done in different capacities in different areas and have that, whatever you want to call it, success or impact, that's exactly what happens, right? It's like, oh, I thought I was going to pursue this thing. And then something changed. Yeah. And now look at all these things you've had. Hindsight's 20/20 where you say, oh, of course that made sense. But looking forward, sometimes that's challenging.
Very hard.
But you have to be able to have that perspective, especially I feel like it relates so much to why we're here today in the conversation that we're having, right? Like we started this podcast because we believe that we need a better standard of care, that motion or that fusion works for some, but there's better options out there. And you have to have that perspective that's like, I'm going to be open to see what's in front of me and I'm going to explore, I'm going to be a rebel and I'm going to see what else is out there. And I think it's people like you, it's surgeons like you that have to be able to have that open mindset for us to even be able to say, are there better options? How do we seek them? And how do we not just give up when you hit that first hurdle? Because it's difficult in medicine just to give a standard of care and be like, I want to have success with patients, but to say, I want to go and look for new options. I want to see what other things are available to patients. That's really difficult to do.
First of all, thank you. I don't consider myself such a big innovator, but I consider myself a good listener. And you need to have a certain level of humbleness to succeed in life, which means that you need to acknowledge your own shortfalls, which also means you look at your patient and you see how they struggle. And it would be inhuman to not think, how could I have done this better? what could I have done differently? And by just staying curious and asking these questions, and by staying humble and listening to your patients, you learn. You learn, and they inspire you to go like, is there another way? Is there another way that makes sense? Often I go to a conference and people show X-ray after X-ray of how great they are. And I just sit there and I go like, I wonder how the patient did. And that is the key, It's not showing this smart X-ray of how you did and what you did and how you corrected this and whatever. Very few people talk about how did the patient do? How did the patient perceive this?
Mm-hmm.
And I think that should be front and center, both when you adopt new technology and when you seek it, because you have to be very ethical in the application of it, and you have to be thoughtful in what can make the outcome for the patient better. Doesn't matter what the X-ray look like. And I've had great mentors in my life who had taught me this. When I showed my first X-rays as like a young attending, like, look what I can do. And they go like, yeah, I see that, but how did the patient do? And I immediately heard that and I go like, yeah, I got to look at my patients. And I think that should be the driving factor. What do we do that can make the journey that the patients go through with spine problems less arduous, make their recovery better, and reduce their morbidity?
It's a common thread that we hear with the surgeons that we sit down with. I think that humility is a huge aspect of it too. Just being a listener, being naturally curious. Because I think as you look at surgeons and the medical community in general, you look at surgeons as the people that are the best of the best at what they do, right? I mean, if you want to talk about Olympic athletes, like surgeons are right up there in our society. That is about as much training as you could do for anything you have to do to get into surgery, orthopedics, neurosurgery, just any surgery in general. And to have that kind of natural curiosity and that self-reflection to look back on those things, I think is really impressive. So I want to bring it full circle to where we are today. So now here we are today at the University of Colorado. You're the department chair of orthopedic surgery. You've been here for 16, 18 years now. You've been here a long, long time. You're in leadership positions. You're a professor here. What made you what made you move from LSU to here, make the jump, and then talk about what you've done since you've been able to be here?
What really made me make the jump was Hurricane Katrina. And a year after that, Dr. Robert D'Ambrosia moved here, and still in Bob style, he phoned me up and he says, so, are you ready to move now? Didn't ask me, did I lose my home? Am I okay or whatever? I said, I'm not sure, Bob. He goes like, well, you should come and look here. I need a spine surgeon. So I flew up, and as always, he didn't take no for an answer. And we came. This campus did not exist when I came, 2006. There was one building here. It was still the old Fitzsimmons military bases and Army Hospital. And I've been here for every move we made from downtown to here, to every building that's gone up. I've advocated at many building meetings for expansion. And now when I do my 10,000 steps, I go like, what was I thinking?
One building wasn't that bad.
Wasn't that bad. So, and then when I first came here, people said, how do you like it there? I said, I'm regretful for one thing in my life, that I didn't come here early, because I've been able to achieve more in the first year at the University of Colorado than I did in the whole of my career leading up to that, because of opportunity.
Wow.
This is a place of unbelievable, abundant opportunity, ripe for the picking, lots of windows and lots of doors, and you just have to open them. So I came here, I was a senior spine surgeon. It was just me and Vic Patel, who, as you know, is a very big supporter of Premia and doing this arthroplasties. And we grew this spine unit to where we are 8 orthopedic spine surgeons today and 3 neuro spine surgeons. We have a whole spine center with PM&R, all of the facilitating services, physical therapy. We do about 43 cases a week, which is big for any place. We have absolute great partners in all of the other disciplines in the School of Medicine, anesthesia, internal medicine, ICU. Just an amazing place to expand. We have done several FDA trials here, so we are very blessed to be here. In the meantime, I had another hurdle. I got breast cancer in 2010. I was very sick. And again, I lay there and go like, why did this happen? How am I going to finish my career? Will I be able to do surgery? And then I thought, well, if I can't do surgery, how can I use my previous life experience to still be valuable? And I decided to explore leadership. I had no intent ever to be in leadership. And I was blessed to be picked as one of the ELAM fellows. It's an executive leadership in academic medicine. This was a year-long course, online and in person, in Philadelphia. And we were 50 women over the country, and I learned a lot from very impressive women and my peers. And I came back and I became the vice chair. And when Dr. D'Ambrosio retired, there was a national search. And I believe there were over 50 applicants. And I stayed the course, and here I am today. And once I got it, I go like, what was I thinking? So here I am. We've built this department to one of the premier departments in the country. We are a very successful department. We were the first School of Medicine department to go off campus during COVID. 50% of my surgeons are actually working in community hospitals.
Wow, that's amazing.
So they give great care. We are competitive in the private sector. It gives the residents the opportunity to see real medicine, how it's practiced in private practice, how it differs from academic medicine. And we are in the top 10 on the Blue Ridge Book for Research. And our last grant was an ARPA grant that we got this year to the tune of $39 million in curing arthritis. So
amazing.
I'm in my happy place.
Yeah.
I am conducting the orchestra, and I have unbelievable musicians, and they are fantastic. That's where we are.
If little you that was playing with her dolls saw you today, what do you think she would say?
She would think it was a dream, and then it turned into a nightmare. I was the first person in my family to get a college education. My parents wanted it for themselves and never had opportunity because my mom grew up in Johannesburg, and my grandfather then took her out of school when she was in grade 10 and said to her, you've had enough education for women. So she went off to work and then used her own money to educate herself in music. She was very good in music. My dad, the same, was drafted, and then in an attempt to not make him go to North Africa, my grandfather then found him a job as the water fiscal. He was the person controlling the sluices so that the town could have water. And it was considered a key job in those days. And so he didn't go to war, but he also had to leave school. And he went to night school, became an engineer, worked in the steel industry. So I think I learned from them and how little they had and what they could give us as children. And my father did sell the family ranch when I got into medical school, and he gave half of the money to me and half of the money to my sister. And he said, don't expect to inherit anything. I'm giving it to you now. And my sister became an oncologist and I became an orthopedic surgeon. So unbelievable.
Absolutely.
It comes from that drive, from seeing my parents work like they worked and from sacrificing everything for their children. So I think if I was 5 years old, there was no way I could envision this.
Not even be able to see it.
Not even be able to see it.
But it's amazing how far, and like what an investment your father made in both of you. That's what parents dream of, right?
Yeah.
And that you took it that far, and that you're both healers, right? You both take care of people. It seems like that also is in your father's footsteps as well.
Yes, that's true.
I think it's a testament to you too, because, it's amazing what your parents can do and what parents will sacrifice for their kids. But the next step is doing something with that sacrifice, right? And so like there's a lot of other things you could have done with that money, right? Rather than go heal and pursue your dreams and impact. And I think, so that's a testament to you as well, as the amount of work and drive that you've put in after that time point to be where you are, right? Both you and your sister. I think that's amazing. You talk a little bit about this you guys do everything here, right? So you guys do across the board for orthopedics, you do everything. But you personally, you've been very well versed in complex spine surgery, right? Deformity and scoliosis. What was it that made you kind of go down that path and start looking at that? Was that your background in South Africa and what you saw for cases and what kids, dealt with? Or what was it that kind of made you pursue that path?
There were like 600 orthopedic surgeons for a population of 42 million. So you had to be really well versed in all of orthopedics. But after I decided I would do spine surgery, I took another look at people with life-crippling deformities because they were sort of cast aside. As you know, today, if you do these complex spines or big deformities, you don't do that for the money. Most of our patients do not have private insurance, if any, yet they are in desperate need of care. So I think, first of all, I looked at people that were really deserving for care. And I found such a big satisfaction when you took somebody that could only look at his toes and he looks at you and he says, wow, I can look you in the eye. That is just what drove me. So I think being able to help people that are truly in the old term deformed and were really cast out. So I see patients now. I had a patient in the last 10 years who was a little boy with severe scoliosis, most likely congenital, and his parents didn't want to send him to school. So they kept him on the ranch. They hid him because they didn't want the community to know that they had a crippled child. So I did a lot of pediatric in South Africa. I did pediatrics in LSU and adult. And then when I came here, the need was for adult. And adult deformity didn't develop, but over the last 25 years. So if you had that good pediatric background and you started to apply some of these principles in adult, I was very fortunate to meet Larry Lenke in 2000, and we became good friends. And we sort of were both driven from a pediatric perspective, like we should first of all prevent that people look like they look when they are in adulthood. And then we saw people that fell through the cracks and we go like, there should be a way we could fix them. And so I think that's what drove me to the complex side.
You're not the first one that has talked about Larry Lanke being your mentor. And I mean, he has done so much in that space. And then, so as we talk about this kind of across the spectrum, you've started to move into motion preserving options as well, right? You were enroller in the FDA. You talk a lot about clinical trials. You guys were part of the TOP study. You talk about disc replacement on your website. What was it that made you start looking at that? Because for a long, long time, even when you look at, single level and 2-level cases, we did fusions on those, right? And that was the standard of care. What made you start looking at motion preserving options?
A very good friend, best friend, and great mentor who actually helped to discover me in South Africa was John Felgott. And John Felgott came out to South Africa in 1993 and brought the concept of pedicle screws. We didn't have it, came out and taught us pedicle screws, and we stayed friends, and I came to visit him often. And he's a very wise surgeon, and I would show him these x-rays. He says, your x-rays look great, but your patient's going to not do well in 6 or 7 years. And I thought, you're full of it. But then I started to look at my own patients, and I saw that what we did with these long fusions was we took snapshots. You saw a scenario, you took a picture, you did a fusion, okay? But then the scenario changes over the next 5 or 7 years. And then you do another snapshot surgery. And there was no thought process on how do we get the patient out of the situation and provide longevity to the spine. And the longer I do spine, the more I realize that motion preservation is so important. There are people who absolutely do fantastic with the right fusion, right patient, right time, okay, and are very grateful. But the average back pain, which is a symptom and not a diagnosis, being treated with a fusion is wrong. And I will say that in any audience, okay? You do not treat back pain. You treat a organic condition like instability or disc degeneration. But unfortunately, a lot of spine surgery were being done for back pain. And people got that snapshot surgery. And they never recovered and they never did well. And if you then look back, the only surgery they should never have had was their first surgery. And if they had that first surgery, it should have left them with options. So when they came to the next surgery, because now we know a lot of disc degeneration and instabilities and facet arthritis are genetically based, as we look at genomics of spine, that they had options. When you did a fusion, you limited the options to fusion. You chose that path and you didn't leave any other options.
We talk about this all the time.
I mean, so well said.
Yeah,
I mean, I've never heard it in like, don't treat back pain. And I think that's such a good delineation, of like looking at how you look at the problem. So then determining how is the best way to solve it. And it's easy to say, well, you have back pain, so I'm going to just put a fusion in. But if you take a step back and just separate those things, it really does change the perspective of it.
Yes, so I have seen just excellent results with all kinds of motion preservation. I've had people with disc replacement that has achieved very high ranks and served our country in Afghanistan. If you would do a fusion to an Air Force pilot, they would lose their position. So there are so many things where the military and the things that we've been through, and that's again my military background, made me look at what can keep this person functioning as a combat person. And it was not fusion. So I always keep that in mind.
I think it gets focused a lot, when it originally gets talked about, you talk about athletes a lot, right? Because you talk about these Olympic athletes and being high performers. But the truth of the matter is the 95% of people who are going to end up getting motion preserving options are the people that are doing their day-to-day life, right? The people that are serving our country, the people that are working, in farms and doing blue collar work, which is so much of the work here, right?
Yes.
And that's what it ends up being. And I think it gets focused on athletes, which is great because it helps kind of push the narrative forward. But those are the people that we're trying to help, right? Is like, how do you give them functional outcomes, right? Another 15 or 20 years, because we've talked about that for a long time. What you used to do in spine care was remove pain. Like that was your goal for spine care, was removing a pain generator. And now we're looking at how do we get them back to work sooner? How do we reduce operative time? How do we get functional outcomes to where we're just moving the longevity down the road?
Yes. Totally agree.
So what made you start looking at the research side and focus on it? Because you guys have a huge focus on it here. You've been doing it for a long, long time. Is it just that idea of wanting to improve, wanting to do better, and you see clinical trials as a way to do that? Or what was your focus on research? Because you have over 100 publications now, right? It's not like that's a small part of your career. That's been a massive part of what you've done.
It's being self-critical. If you ever read the anatomy book, Gray's Anatomy, there's a chapter in that written by Professor George Domacy. And he was a South African and one of the founder members of the Scoliosis Research Society. So he was like always up there for me. And then when I decided to do spine, he was still there. He didn't do a lot of surgery at the time. He was already senior. But he came to my clinic, and I have a great respect for the people that has gone before us. Mm-hmm. And I would invite him to my scoliosis clinic. And the culture in South Africa was very British, because of the influence. So we would start clinic at 8, and we would have a little tea break at 10, and then we would have lunch from 1 to 1:30, and then we will do the rest of the clinic till 4 o'clock, and then we'll have tea and we'll go home. It's so far removed from what we do today. But we didn't have so many physician burnout, so there's something to say for it. And he would come in the afternoon. He would come after tea and come to my clinic and have a little lunch with me. And he would sit there in the consulting room. And patients would come in pre-op, post-op, and I would talk to him, hear his opinions. And I showed him my post-op results with pedicle screws. And he sat there and he said to me, looked at the x-ray, says, you don't get much more with this than I did with my Harrington rods. And every time you get triggered, you need to know that somebody has hit something that is really true. And I got triggered. And I got, you're retired. What do you know? And then I invited him to come into the OR. I showed him how we place these pedicle screws and how great we are, And after the surgery, he says, yeah, I can see the opportunity. He says, but you're not using this to its maximal ability. And I mean, he had never put a pedicle screw in his life. And I said to him, why do you say I don't get more than you did with your Harrington rods? And he said to me, because your spines are still flat. You've not restored the thoracic kyphosis. And I looked at it and I go like, geez, he's right. And then I went back, and those days we had x-rays. You had to go to the file room. It was like loads of x-rays, and I would carry them and I put them on this light board with my special pencil and my ruler, and I'll measure all these angles. And I go like, but I did bend this rod. I know I did bend this rod. And then I went into the OR, do another scoliosis, and I would contour that rod and really bend it. And 6 months later, I'd look at the x-ray and the rod would be flat. And I started asking the question, why are my rods flattening out? And I started speaking to engineers, and that's where it started. Asking the question of your own work. And I then started my research on the thermoplastic abilities of titanium. I looked at what is actually available in engineering literature. There's a lot written about titanium. It didn't translate to the medical literature. Did some really great research with the help of a lot of engineers. And then it changed industry, and we got pre-bent rods because they understood that once the rod is exposed to 37 degrees of centigrade or body temperature, it changes the thermoplastic behavior of titanium over time, and that you need to anneal it. And then the industry standards start to change. And I go like, wow, I can make a difference. And then I started asking questions. And every time you ask questions, you speak to people that are way smarter than you. And then you can put two and two together with their help. You don't have to know the answer. You just have to be able to ask the question. And so I just love it. Even today, I ask these questions, and you ask it about every patient you do. I was on call last night, and I looked at this really bad transfer that we got. And I go like, what did they miss? So I said, I want the original MRI. So they sent it through the portal. I looked at this and I said, this is not a post-op infection. This is a pre-op infection that they missed. So it's just asking that question. Everybody is angry because we have this patient with a post-op infection from another state that we have to take care of. And I go like, guys, this guy was sick before they did his surgery. They missed the diagnosis. And now everybody is like more willing to help the patient. But it's just asking that question,
Isn't it amazing how an outside perspective can change some of that visual into the problem as well? I think we see this a lot in spine. And you talked about he had never placed a pedicle screw, but he came in and had this perspective because he's never seen it before. So he could have this perspective that you don't have, even though you do it every single day. But then you're able to kind of step back, remove yourself from the process and say why am I not seeing this thing? Or what should I be chasing here?
This is so important. That's why I said when new technology comes, you have to be so careful. Because it's so much fun to be on the bandwagon. It's so much fun to be on that podium and to say, we did the first 300 cases, But you have to be so careful because not all new things came to stay and not all new things are good. And a good craftsman knows the history of his craft as well as the craft. And you have to look at the history. One of the big icons in orthopedic surgery, Sir John Charnley, who invented the hip, did this, he was ostracized, almost lost his license to practice. And then his hip started to fail. And then he stepped back and looked at it, and he revised every single hip that he put in. And you just need to look at people like that who's changed forever, who's changed what we do forever, and how responsible they were in the technology that they bring. And the one golden lesson in spine is never put anything in that you cannot take out, because then it's a bad place in the first place. So you have to always have that little voice in the back which asks the question, is this the right thing? Am I doing it right? Can I do it better? And that's what I try to teach my fellows and residents. I teach them the principles of surgery. And I don't think they like me a lot in the first 2 weeks because I keep on saying, don't do this, don't do this, don't do this. And I think our younger generation goes like, well, I've done this before. I'm finished my residency. And I go like, I'll tell you why you shouldn't do it because I've done it and I can tell you what can go wrong. And you don't have to make the same mistakes that I made. You can just learn from mine and start at a higher level so that you can be better than me when you finish at the end of the year.
I think that's incredible. You go back to you being a lifelong learner and how you've innovated on these different techniques and procedures. One thing that I love, and I don't know if I've heard it explained this well before, is when you talk about treating as a snapshot of time. There are tons and tons of patients that I think are now and will continue to get motion preserving devices in the future, probably more so. And the truth of the matter is, we're still going to have complex deformity cases. They're going to exist, right? We're going to have scoliosis. We're still going to have some of the problems that we see, right? PJK and ASD, some of these things that we run into. I'm curious what your thoughts are. We've heard this kind of different ideas of even using like these things in conjunction with each other, right? Like using motion preserving options as a hybrid or adjacent to a fusion, because fusion constructs are going to exist. They're going to exist, but how do we take like the next step and hopefully preserve what's next to it? And I'm curious if you've explored any of that or what your thoughts are on that concept.
My mind has explored it a lot. We run into a problem, and that is that level of research and developing new methods and implants, it's hugely expensive in this country. And in our mind, we know what we want, but you need to find the right partners, and we have to find industry partners and people with bigger pockets, and we have to define the problem that we want to solve. And then you get the grants, the seed grants, and you start working on this. I do totally agree with your perspective that hybrids are fantastic. At the moment, it's not being done because the insurance won't pay for it.
Mm-hmm.
And unfortunately, our care and our liability in this country makes it difficult to do quote unquote experimental care, even though the patient would sign up for it and go like, please, I'll do this rather than the fusion because you don't have the indications. So there is a huge gap that we have to bridge with proper research. I do think that a lot of the research dollars is now being shifted to prevention in terms of why are you getting this scoliosis? Why do you have sagittal imbalance? Why do you have this degeneration? Hoping to solve this with all kinds of enomics, proteomics, genomics, every omics that you can think on. These big data is really important because we've never been able to analyze big data in the way that we have now. If you look at the history of AI, it's done blips all over the market since the 60s, but it never got the traction that it has now. It took a lot of industry developments and advancements to come together on different platforms to be implemented into medicine where it can actually benefit the bigger population. So hopefully, unfortunately not in my lifetime, we will be able to do a screening test, a genetic screening test when somebody's born, to know exactly what are the diseases they're going to develop and intervene early. And, all this might be an archaic video that people look and go like, what were they thinking? And I hope that would be the case. I really do.
It's funny, we talk about that all the time, is like you almost hope 10 years down the road or 20 years down the road, you look at what you were doing and say, I can't believe we did it that way, right? You want innovation to move forward, and it happens, and you essentially have to use what's best at the given time, right? Like we only have access to so many technologies. We've seen it with, you talk about AI, we've seen it with motion preservation as well, right? Where like blips in time, it was like really, really important, and then it kind of fell off, and because, you have some problems and some things happen, and then it comes back, and then you figure out how to do it better, right? And how to place devices better, and the technology gets a lot better, and then it starts to creep back up again. And how do you get the groundswell to bring everything together at the right time and get the right buy-in? Because we could have another 3-hour conversation on insurance and reimbursement and how that influences care decisions, because that plays a role too.
The GDP of this country, as you know, everybody talks about it, that we spend 26% plus in medical care. That's not just orthopedics, it's across the continuum. What I can do in my short lifespan that I have left is to keep on advocating for great orthopedic care. Because our medicine colleagues became so much better, our cardiology colleagues and whatever, that we are now facing an aging population, an aged population that we would never have seen 20 years ago. We are seeing people making it to the hospital alive after car accidents because the technology in cars have improved with fractures that you go like, how is this person alive? You would learn about these things and say, this is only fractures that is diagnosed on postmortem. And now we see all these patients coming, okay? And what we can do now is to keep up with this new demand on care. And we are constantly seeing pathology that we've never seen before because people are older. And you go like, what? What is this? And using what you have in your armamentarium to do the best you can for them at that point is probably very important. What we do need to advocate for is that orthopedic care in general, spine, arthroplasty, sports, is life-changing. And it's actually more cost-effective than letting people suffer on in pain. If you look at the narcotic epidemic, it's been well proven that we can make an intervention that improves the functional outcome of the patient dramatically and takes them even out of like frail care facilities because they can walk again. And so I think I enjoy advocating as much for the deformed child as I do for the older patient who has a lot of life left but has no quality in that life.
We talk about that concept all the time, right? There's the pain reduction side, and then there's the how do we improve quality of life side of things. And like you said, the care continuum is changing, right? How do we change from, and this is medicine in general, we treat patients retrospectively. We do it across almost everything. But now when you talk about sports medicine and orthopedics and arthroplasty, total joints, we can insert ourselves in sooner and not let people suffer, right? We can stay away from some of these topics, but the people who lead that charge, they take arrows and they get ostracized. You talk about Sir Charnley. We talk about him all the time, right? And so when you go out and do this research and you push it forward, it's not always easy and it's not always fun because you have a lot of people saying this person's insane, they don't know what they're doing, or like this is not safe, but you have to kind of step in front to do some of those things and move the ball forward.
Yeah, it's interesting. If you look at the bell curve of adoption of new technology, you have your early adopters, and then you have your trepidatious group that come along, and then it peaks, and then you have your laggers, okay? But the key is to get everybody to be somewhere on that bell curve. The danger lies in people that are rigid and go like, I've done this for 30 years and it worked in my hands, I'm not going to change my technology. And that is, in my opinion, a dangerous practitioner. Doesn't matter what you practice, okay? You have to be open to new technology and you need to be able to step back from your own work and look at your patients and go like, what is the harm I can do? What is the good I can do? Is it worth trying this technology? And if I don't feel comfortable in trying it, I'm going to send this person to another physician who does this. And that's the nice thing about our big group. One of the leader of our spine team, Dr. Christopher Clegg, is a brilliant, gifted surgeon. And he does a lot of cancer, deformity, and infection. And he spends hours in the OR. But when he sees a patient with a single-level spondylolisthesis, he goes like, hey, there's a new technology out. I didn't train in that, but my partner does. You should go see her. And just have that, give the person the choice to do this.
That's what patients deserve, right? We talk about that a lot of that. Should be a bigger toolbox and patients should at least know all of their options. And so often they aren't told what they are. And I think that's some of the apprehension that has happened in the spine space for patients where it's become I know I don't want a fusion, or my sister got a fusion, my grandma got a fusion, so I don't want it. And so they wait longer and longer to get care. And what we're talking about is really it's better if they come in earlier to get care, but it's hard because you have those two conflicting things. But for patients to have the ability to know the spectrum of care that is available to them. And it does take, colleagues saying, hey, not in my hands, but in someone else's hands, you're a good candidate for that. So I think that you should go and see them. I think that's huge.
Just have to do it. You just have to go like, if this was me, would I like a second opinion? And would I go for this surgery? You always have to ask, put yourself in that, Like I said, people ask me all the time, well, would you think I do this surgery? Because I said, I can't do it right now. I said, well, I'll recommend any of my partners. I said, they actually did my husband's surgery And I actually like him. So I think they can do yours.
That's great. I'm curious, going back, focused on motion preservation a little bit more. I'd love to hear your thoughts on, I loved your analogy of AI. We went up and down and up and down. Where do you think we are with motion preservation right now? And what do you see in the future for kind of how care is going to shift in the next, 5 or 10 years?
I think we're in our infancy.
Mm-hmm.
As people get past their 5 and 7 and 10 and 15-year marks of disc replacement, facet replacements, all of this, it will definitely spur on other technologies, which we see up and coming, rising a little bit. So that would be fantastic. I think will be on us to prove to insurance companies that hybrids will be the thing of the future. So if you've had a fusion before and you have that next level that you can actually do a motion preservation level surgery. So I'm very excited for motion preservation. I think we're truly in our infancy. So if the bell curve is like that, we're right here where the car is just starting to pull away.
And that's why research is so important, though. Like the commitment to research. And we talk about all these different aspects. It's not just a lack of patient education. Like you said, if you're doing what you did 30 years ago, you're probably not providing the highest level of care that you possibly can, right? And so part of that is like being able to educate and talk to colleagues and other surgeons, because it's tough. It takes time, right? And if you're not publishing research that can be viewed and accessible, the car slows down, right? It doesn't keep moving down the road. And I think there has to be a commitment in people that are willing to carry that flag forward in order to do that. And, we've talked about a little bit, we talked about AI, we've talked about some of these hybrid constructs. When you look at, the rest of what you have in your career, whether that's 5 or 10 or 15 or 20 years, what are you most excited about seeing? What do you think is going to change like the paradigm of spine, or what's coming that's going to impact patients the most?
That's a loaded question. In the surgical realm, you must remember that anesthesia and post-op care is dramatically improving, just as we are improving surgical techniques. And I see this because we have this complex spine pathway where we involve our medical colleagues now pre-surgery, and they help us take care of these patients post-surgery. I cannot be the perfect post-op hospitalist and a surgeon. So even though technology will be slow to adapt, and I see the most benefit in the way that we treat patients preoperatively to get them ready for their surgery, moving from a complex 5-day stay to an overnight stay with all kinds of techniques, anesthesia, pain management, better optimization, making sure hemoglobin, A1Cs are right, the whole teeing the patient up, okay? Every time you do a surgery, it's like going camping. You don't just jump in your car. You have to make sure you have your tent, your water, your food, your emergency flashlight. Surgery is just like a camping trip every day. You cannot just go. You might get snow. You need a shovel. You might need an emergency radio. People don't think about it that way, okay? But what happened in the old day, you needed a trailer. Now I can put all of that stuff in the backpack. So I think that's where we're going. We're going to be more nimble and providing patients access and tools, home monitoring, home oxygen, all the things that we can do remotely now opens up a whole new world for patients in terms of how they experience the surgery while we keep on working on the technology to change.
That's such an incredible analogy. And I think we're in the sweet spot of seeing a lot of that, right? Getting patients to the right state preoperatively. And then you look at ERAS protocols and you look at just getting patients in the essentially just outpatient setting, right? And we're seeing more and more work done in ASCs in those environments where we would used to hold patients 2 or 3 days. If we can get them out sooner and get them up in ambulatory sooner, we're figuring out that that's a better thing in a lot of situations, right?
Yes.
So how do we move the camp? I've never heard that analogy. It's so good. How do you make the camping trip from, filling up a van to putting it in your backpack and moving forward? And I think we're right there. Well, we appreciate so much you taking the time to sit down with us today. We have been just so fortunate to sit down with you. We've been very excited for this one. I want to reach out to all the patients out there. For the patients that are looking for you, where can patients find you? Where, if they said, I want an appointment with Dr. Burger, where can they find you?
I'm very blessed to work at this beautiful campus, which you've experienced in sunny Colorado. And I am at the University of Colorado Hospital and we have a spine center. And you can just ask for the spine center, and they will answer the phone. Okay.
You're not tough to find. Yeah,
No, we're not tough to find.
That's amazing. Well, we appreciate it so much. We know you're busy. We know you got more going on, so we don't want to hold you any longer. But we thank you so much for sharing this experience with patients and all of our listeners, and really appreciate you taking the time to sit down with us.
Well, thank you for coming out.
Yeah, it was an honor to get to hear from you and your perspective.
Thank you very much for including me. Appreciate
Awesome.
it.
Thank you, Dr. Burger.